All right, what's going on, guys? Another edition of Monday Nights with Mike Livestream Q&A. Ask me anything, health related. So, ask about the caveman Livestream. You really got to work on that. The Livestream thing's throwing me off a little bit in terms of how to open it. And yeah, so how you guys doing? And tonight we're talking about a couple of different things, but again, it's open Q&A, so you can come in with whatever it is that you're feeling happy about watching, whatever it is you want to do. But the topics we have on hand already are niacin, which is better known as vitamin B3, and echinacea. So we're going to build off of those topics and yeah, move forward. So that being said, let's get right into it. So let's pull up our first article about whether or not there are benefits to supplementing with niacin. And the way we're going to do that is we're going to look at, first of all, rats. Don't worry, we're going to go to humans next, but we are going to start with rats. Here we go. Boom. So the effects of nicotinic acid or niacin, vitamin B12, like vitamin B3 or niacin, on the lipid profile of diabetic and non-diabetic rats. And if you look down in the description, that article is down below. I'm actually going to go to the settings and flip those because I decided I am going to do niacin first. I'm going to fix that real quick. Boom. If we look down there, oh, now should be fixed. So our first article, like I said, is going to be on the rats. Here we go. So looking at this here, we have determine the efficacy of nicotinic acid on the lipid profile of diabetic and non-diabetic rats. The method, this experiment was done at the Institute of Molecular Biology and Biotechnology at the University of Lahore in Pakistan between May 2010 and July 2010. Basically, they gave vitamin B3 to some hypercholesterolemic group and a hypercholesterolemic plus diabetic group of albino rats for 42 days, and response to therapy was recorded on day 21, day 42. So halfway through the experiment and at the end of the experiment, they compared the lipid profiles of rats that had high cholesterol, both as diabetics and non-diabetics. And what they found was that the values of serum total cholesterol, triglycerides, LDL, so low density lipoproteins, cholesterol, and total lipids showed highly significant decrease, whereas serum high density lipoprotein, or HDL, the good cholesterol, showed highly significant increase, which is a good thing. So, nicotinic acid is the most effective agent available in increasing HDL cholesterol and lowering serum triglycerides, total cholesterol, LDL, and total lipids in hypercholesterolemic, diabetic, and hypercholesterolemic non-diabetic albino rats. So, in rats, B3 appears to be very effective at taking care of your blood lipid levels. Go through quickly, not going to go through the whole study on this one. If you want to do so, like I said, the link is down in the description. It is Zeb Shah et al. From 2013. Oh, sorry, but that expanded on me there. But long and the short, we have here the breakdown of their total cholesterol, the HDL, everything there. So at the end of it, the descriptive statistics of measurement levels and milligrams per deciliter of all those showed significant decrease in hypercholesterolemic non-diabetic and diabetic groups. Although the improvement in lipid profile in the diabetic rats showed very slight lag, the results are marvelous. These results are consistent with previous studies on non-diabetic dyslipidemic patients, as well as studies on diabetic dyslipidemic patients, so both non-diabetic and diabetic patients. Several studies have shown that nicotinic acid does not increase the synthesis of HDL-C, but inhibits the selective uptake and degradation of apoprotein A by the liver. Basically, doesn't increase HDL, doesn't cause you to make more of it, but what it does do is it stops the breakdown of a portion thereof, a segment thereof. In the process, cholesterol ester in the HDL particle is taken up by the liver, and apoprotein A is thrown back into circulation, which is the carrier protein of the HDL particle. There you go. As such, more carrier protein is available for binding to HDL, and as a result of that, HDL is available in circulation for longer periods and in larger quantity. In our previous study, an increase in HDL was seen in hypercholesterolemic, non-diabetic, and diabetic rats. This is consistent with like this is inconsistent. Inconsistent sounds like it's inconsistent, but yeah, this is consistent with, because that's a better way of wording that. Consistent with a study where results of nicotinic acid administration to a group of rats was compared with a control group, as well as a group which received 1 mole per of the dexamethasone, and another group which we received dexamethasone plus nicotinic acid, or B3. Increase in serum HDL was highest in the group that was given nicotinic acid. There was also a decrease in serum total cholesterol as well as in serum LDL to the level even lower than the control group. Moderate fatty liver changes were seen in 1/3 of rats on dexamethasone. Rats in the control group and the group receiving nicotinic acid and the group receiving both did not show signs of fatty acid changes. This is in agreement with the study called the Assessment of Diabetes Control and the Evaluation of Efficacy of Niaspan trial carried out on diabetic patients. Similar results were obtained in another study that Arbiter. Yeah. Basically, moving past that, because we are going to go to the human stuff in a second. That way we can kind of just blast right through. There were highly significant decreases in total values were seen in response to the administration of nicotinic acid. It was in correlation with the study conducted in 1964 carried out in human beings. The decrease in total lipids occurs in consequence to the cumulative effect of changes in the lipid profile. So, conclusion. The present research work shows the effect of nicotinic acid on the lipid profile of diabetic and non-diabetic rats was highly significant. Nicotinic acid decreased the levels of serum total cholesterol, serum triglycerides, serum LDL, and total lipids, and it increased the HDL lipoprotein cholesterol in both diabetic as well as non-diabetic rats. Now, to be clear, as we talked about on a number of occasions, I don't view the lipid profile as being the absolute arbiter of heart and cardiovascular health. But again, they are biomarkers that have a purpose, and a little bit more of that will be touched on in the next set. So in the study on the humans, which is right here, the effects of niacin on atherosclerosis. Imagine I can't say that one, right? That's fun. And vascular function. And is Ruparellia, Digby, and Chowdhury. And this was in the current opinions of cardiology. Basically, excuse me, the purpose of this review the purpose of the review is that niacin has been used for over 50 years in the management of atherosclerosis and is associated with improved patient outcomes. The routine use of niacin has been superseded in recent years with the advent of newer lipid modulating interventions. Recently, however, there has been renewed interest in its use due to the appreciation of many beneficial effects on atherosclerosis and endothelial function, both lipid targeted and pleiotropic. This review will consider the effects of niacin in the setting of clinical trials and will critically evaluate proposed mechanisms of action. The identification of the GPR109A receptor has promoted a greater insight into niacin's mechanism of action, with demonstrated beneficial effects on endothelial function and inflammation, in addition to its lipid modulation role. And therein lies the key. So when we're talking about niacin specifically, you say right there, endothelial function and inflammation. So, or rather, when we're talking about the lipid profile specifically, a bigger aspect is there underlying inflammation? Are we dealing with a lot of damage? Because we've talked about before, HDLs are kind of, again, gross oversimplification, but they're kind of like the taxi that's shuttling cholesterol out into circulation it's kind of like the taxi bringing cholesterol from circulation to the liver. Yeah, reverse that for a second, sorry. To the liver to be cleaned out. And that's why it is good. It's clearing out cholesterol. Whereas LDL is bad because it's taxing and shuttling cholesterol out into the system to deal with inflammation, to deal with mounting inflammatory response. So, in that case, if we have less inflammation, then we should be able to see a net benefit on your lipid profile. There should be more coming back and less going out, right? All right. Summary. Whether niacin itself is used routinely in the future will depend on the outcomes of 2 large outcome trials, AIM High and HPS2 Thrive. In the future, however, With even better understanding of niacin pharmacology, new drugs may be able to be engineered to capture aspects of niacin that capitalize on benefits more specifically and also more selectively to avoid troublesome side effects. And therein lies the catch, and that's why this video is coming up in the first place. Are there benefits to B3? Let's try that again. Are there benefits to vitamin B3? Yes. Are there potential side effects? Yes. And we're going to talk about that in a second. In terms of its net overall benefit, I would say you're better off either A, supplementing with it responsibly, so make sure that you are sufficient, but not necessarily megadosing, and B, eat some real food. Most foods have the B vitamins in them. You'll be pretty good. Um, Here, foods. All right, let's go. The World's Healthiest Foods is actually a pretty solid website in terms of actual data. They actually do pull it back generally from the USDA database. But here, root foods that are rich in vitamin B3. Tuna, you can get 156% of your daily intake, your DRI, your daily value, or your daily recommended intake from tuna. Chicken, 97%. Turkey, 83%. Salmon, lamb, beef, sardines, peanuts, a little squirrel, whatever. Shrimp, and brown rice. You know, that's only 20% anyway. But yeah, long and the short, the B3 vitamins, you're going to be getting them in if you're eating some real foods. If you're eating things that are completely refined, then yeah, no, probably not going to get enough in. Other convenient mushrooms and asparagus, all of your excellent and other sources are animal derived. So get some animals in, get in some mushrooms and asparagus if you absolutely must stay on the vegan vegetarian end. Yep. Anyway, there you go. Tuna, chicken, criminy mushrooms, turkey, salmon, lamb, beef, asparagus. Tomatoes, pretty good. Just a couple of tomatoes, get those in. Bell peppers, awesome. So vitamin B3, eat your real foods. But we will also come back and we'll take a little bit more about how it actually works. So the use and effects of niacin on plasma lipoproteins were first described over 50 years ago. In pharmacological doses, niacin reduces low-density lipoprotein cholesterols, very low-density lipoprotein cholesterols, and lipoprotein A. In addition, it is the most effective currently available drug for raising HDL lipoprotein cholesterol. So again, we're talking about here megadosing of niacin. Now, niacin was the first drug to show efficacy in reduction of both major cardiovascular events and mortality in patients with prior myocardial infarction. However, the routine use of early preparations of niacin was limited by the side effect profile, most notably cutaneous flushing or redness of the skin. And anybody that's taken too much niacin will know that that is going to happen. Hey, Annie, what's up? So, awkward question. Have you heard of anyone having bright yellow, greenish urine after B vitamin supplementation? And no, that's not a weird question at all. The neon yellow, definitely. Greenish, not too familiar, but I'm pretty sure we're probably on the same page here. But absolutely, yes. So there's a joke in, in the supplemental world in terms of basically if you're taking a multivitamin, you're looking at this expensive urine. And yeah, the B vitamins, along with vitamin C, they are water soluble, and as such, you very much could pee them out pretty quick if we are megadosing in general. In this case, kind of like how there's discussion of whether or not intravenous or IV vitamin C could have benefit on selectively killing cancer. There's been some interesting research way back, but it kind of was looked away at. It was kind of discredited in the sense that vitamin B3 here, same thing, in that B3 appears to be incredible at getting rid of a bad lipid profile, but then statins came out and all of a sudden, screw vitamin B3. So, same thing with vitamin C, same thing here, the niacin. Niacin could potentially be a very good thing. If you megadose it internally, there's a couple of factors involved, but some of them have to do with both biochemical competition, where the various micronutrients are competing with each other for absorption. There is the fact that if it went in a pill form, it's less bioavailable in general, so you're not going to get most of that. Basically, the long and the short of it is that you're going to end up peeing a lot of it out if you are megadosing stuff. So your body can't absorb it fast enough. In the case of the niacin here, we're looking at specifically the ability to reduce this in pharmacological doses. So this is one of the few cases where megadose might be appropriate. Kind of the vitamin C might also be appropriate in certain conditions. But here we go. It was largely superseded due to the advent of better tolerated therapies for dyslipidemia, and by particularly by high efficacious and well tolerated statins. Ugh. Yeah. The problem with the statins, of course, is that they're going to melt your brain. In short, we've talked about that before, but basically, the mechanism by which it works in reducing cholesterol, besides the fact that cholesterol is the vast majority of your brain, that's how it melts your brain. It's gonna melt your brain first of all, but that's again me being a little bit hyperbolic, but only slightly. There's a lot of neurodegenerative diseases associated with statin use, but anyway. Regarding why it's a problem for people with cardiovascular disease, with heart disease, is that the mechanism through which statins work to lower cholesterol is actually the same mechanism by which HMG-CoA reductase is the name of the pathway. It's also the way that we actually produce coenzyme Q10. And coenzyme Q10 is essential for proper heart function. So a deficiency of coenzyme Q10 is actually associated with heart failure independently from your lipid levels. So we're giving people a drug to lower cholesterol that in turn is going to potentially induce heart failure. Yeah. So definitely, if anybody's actually on statins, to go and definitely something like CoQ10. Anyway, moving past that. At least that's how I would do for legal purposes. Anyway, for a number of reasons, there's been a recent renewal of interest in the use of niacin. Firstly, there is an appreciation that despite effective LDL-C reduction, there remains substantial residual risk in patients with established atherosclerosis. Based on epidemiology, historic trial data, and study of animal models, which we saw before, HDL-C elevation is a rational next target. Secondly, contemporary niacin preparations have a superior tolerability profile compared to early versions. And thirdly, there is emerging interest in several potentially beneficial non-lipid mediated effects of niacin, e.g., their anti-inflammatory effects. And there we are. That's what we were talking about before. It's not the cholesterol in and of itself that is the problem. That is the fireman going out to put out the fire. Again, gross oversimplification. But the fire is that inflammation that's going on. If niacin has anti-inflammatory effects, the fact that it changes your blood lipid profile is more of just indication that it's working, kind of, if that makes sense. Funny enough, statins, that's probably the way they work as well overall. Statins likely work more on a inflammation mechanism. I did the video on that. We've talked about it before. We can go more in depth on it now if you'd like, but that's the short version of it for now. Is that ironically enough, niacin may actually work on similar mechanisms as statins in the sense that it has an anti-inflammatory effect and appears to actually change your blood lipid profile, but not necessarily in the manner that, or that's not necessarily the mechanism by which it's effective. It's more of a side effect, but not necessarily, side effect that John thought was deleterious, problematic, but a side effect as an effect on the side, literally. Yeah. Anyway, back to the point. Recent studies have illustrated the use of niacin in combination with contemporary statin treatment can slow or reverse the progression of atherosclerosis in patients with dyslipidemia and established atherosclerosis. Whether or not this is translated into clinical benefit will be determined by two large ongoing outcome trials, the AIM-HIGH and the HPS2 Thrive. I wonder if those studies came out. I probably should have looked into that before this, but you know what? Let's find out. This is a paper from what, 2012, I believe, or 2011. So theoretically, by now, these studies should be at least some preliminary stuff going on. I don't know why I'm trying to copy aim high if I don't know how to spell aim high. All right, here we go. The 2014 paper. Is there more updated from that? Let's find out. The results of it were published in Journal 2011. Study showed no incremental clinical benefit from the addition of high-dose extended-release niacin to statin therapy during a 36 follow-up in 33,000 patients who had atherosclerotic disease. Low baseline levels of high-density lipoprotein and elevated, we had low baseline levels. In this article, we provide data on adverse effects resulting in reduction in dose discontinuation of the drug. These results were largely consistent with previously established side effect of itching, flushing, gastrointestinal systems, and increased blood glucose levels. Less common effects include abnormal liver function and myopathy were also reported. So the excess of adverse side effects observed in the treatment of HDL to reduce the incidence included unanticipated increase in infections and bleeding. There has been interest in whether similar patterns of serious adverse effects were observed in the AIM-HIGH trial. Important to note that in HPS2, a different studied drug, which was Tredaptive, a proprietary extended-release niacin preparation combined with laropipirant, prostaglandin D2 receptor 1 antagonist, were used to retard cutaneous flushing. So they went and actually added another drug on top of the statins. So that right there could be not necessarily the best indicator of what we have really going on. Okay, hold on. Although the full list of serious adverse effects suggests certain similarities with the data, particularly regarding serious adverse infectious events, the non-significant numerical excess in adverse bleeding events with niacin cannot be considered definitive. Accordingly, there are compelling reasons to interpret this data with caution. In summary, treatment with extended-release niacin was associated with significantly increased rates of certain serious adverse events as well as increased rates of dose reduction or drug continuation in most cases. To known side effects of niacin. Examination tie record of all adverse events suggests other possible side effects of this proprietary extended release formulation. The findings concern certain serious adverse infectious events associated with niacin have not been previously reported. However, lacking additional clinical and scientific confirmation, we believe they should be considered to be provisionary and exploratory. So essentially, in this case, this is the follow-up results, and in this case, honestly, what we're looking at are some squirrely adverse effects afterwards. But we're looking at it in the context of what's likely more a contraindication versus what actually happened. But like I said, don't mega dose your vitamins. Maybe not a good idea. So it's potentially either way on this. It's the fact that they're taking it with a statin, which I already have problems with, as well as the prostaglandin antagonist, so it's antagonizing the inflammatory response there. Might be a problem. So, anyway, moving past that, that is the follow-up there. So, right now, a lot of people just continue because of the negative side effects. The fact they're being taken with the statin, we'll see. So, clinical effects of niacin. The Coronary Drug Project was the first clinical trial to show benefits of it in patients with a history of myocardial infarction. It reduced the incidence of non-fatal reinfarction by 27% in the initial 5-year follow-up period and was associated with a significant decrease of 9% in all-cause mortality at 15-year follow-up. Subsequent clinical trials have investigated the effects of niacin in combination with other lipid-altering agents, such as the FATS, or familial atherosclerosis treatment study, which was a double-blind trial assessing the efficacy of niacin in combination with cholesterol, a bile acid sequestrant, in comparison to lovastatin, or conventional therapy, which was placebo, or cholesterol if baseline LDL was elevated, with documented coronary artery disease and a family history of coronary artery disease. HDL-C increased by 43% was associated with angiographic atherosclerotic regression in 39% in the niacin and cholesterol group, with an associated significant outcome benefit with a 73% reduction in clinical events, which would include death, myocardial infarction, or revascularization for worsening symptoms over a 2.5 year follow-up period. So, long and the short, your HDL count was increased by 43%, and in terms of the actual atherosclerosis, uh, there was a reduction, so regression, there was a reducing of by 39% in that group, with a 73% reduction of dying or another heart attack or the atherosclerosis progressing. Anyway, a couple more there. So again, it's one where there does appear to be some clinical benefit in conjunction with statins. Maybe not a good idea. Statins in general, probably not a good idea, but listen to your doctor, right? Gotta say that. So we have here again effects of lipids and lipoproteins, to that before. Kind of going through this quick. Let's go through the effects of niacin on inflammation. Let's go through this quickly. At which point, once we blast through that, we'll look at. Um, after we blast through this real quick, we can look at the conclusion, and then we'll go over to echinacea. So, atherosclerosis involves complex inflammatory processes that are manifest both locally and systemically, as well as its favorable effects on lipid profile and metabolism. It has been proposed that niacin therapy can also make contribution to inflammation amelioration via mechanisms unrelated to its effect on lipid and lipoprotein profiles. The pleiotropic role may play a significant role in the beneficial effect of niacin on cardiovascular outcomes, both systemically and at local cellular level. Elevation baseline levels of the inflammatory marker C-reactive protein, or CRP, has been associated with an increased risk of future myocardial infarction, stroke, peripheral vascular disease, and cardiovascular death in otherwise asymptomatic individuals, and also in patients who have suffered from acute coronary syndrome. Niacin reduced the levels of CRP and lipoprotein-associated phospholipase A2, which is also an independent risk factor for cardiovascular disease, and it was able to do so after 3 months of administration. By virtue of a high GPR 109A expression levels in adipose tissue, it is not surprising that niacin exerts many of its effects here. Adipose tissue functions as an active endocrine organ. So, your fat levels, or rather, your body fat basically acts as a hormone producing organ. It does so by secreting a variety of pro-inflammatory adipokines, such as leptin, tumor necrosis factor alpha, interleukin 6, interleukin 10, and monocyte chemoattractant protein, or MCP1, and the anti-inflammatory adipokine and adiponectin, or the anti-inflammatory adipokine, the anti-inflammatory adipokine adiponectin. Third time's a charm. Adipose tissue excess, excess body fat, and dysfunction influences both local and distant inflammatory processes which are involved in the progression of vascular inflammatory disease and atherosclerosis. So, high plasma levels of adiponectin have been shown to be associated with lower risk of myocardial infarction in men and moderately decreased risk of coronary heart disease in male diabetic patients. Adiponectin levels are also reported to rapidly decline following acute myocardial infarction. Can't speak tonight, sorry. Recent human studies have shown that treatment with niacin leads to a marked increase in plasma adiponectin, which has been demonstrated in the rat models to likely be mediated by the action of niacin on GPR109A in a dose-dependent fashion. Proatherogenic chemokines, which are regulated upon activation through normal T cell expression and that's secreted, as well as fractalkine. They are secreted by adipose tissue, contribute significantly to the recruitment of inflammatory T cells and macrophages in atherosclerotic lesions. Niacin administration has been illustrated to suppress tumor necrosis factor alpha induced expression and release of these chemokines, thereby exerting a significant anti-inflammatory function either through the modulation or regulation of perivascular fat that might drive the atherosclerosis or through another indirect mechanism. So, breaking that down, long and the short is the chemicals that are released, chemical mediators, chemokines that are released to induce atherosclerosis or atherosclerosis is they're secreted by your fat tissues. They are able to recruit, they're able to bring more inflammatory T cells for your immune system, as well as macrophages, to the atherosclerotic lesion. So, we've talked about before, the LDL, right? It's bringing cholesterol out. It's the drive. So, the LDL is not the cholesterol in and of itself. What it is the taxi that's driving these to the site of the inflammation. In this case, the atherosclerotic lesion is essentially a cut. The plaque that builds up on that lesion is essentially a scab that's filling that cut. So we're sending an inflammatory response here. The T cells and macrophages are going along there. Now, the process of administering niacin, so the vitamin B3, has been illustrated to suppress tumor necrosis factor alpha, which is another chemical mediator, and it also suppresses the release of those other chemical mediators, the previous ones, MCP1 and RANTs, etc. Thus, in that process, by blunting the release of those chemicals and by suppressing tumor necrosis factor alpha, it can reduce inflammation. By reducing the inflammation, it can reduce the clearing out, or it can help to deal with the lesions that were induced by them. Niacin, therefore, in addition to its lipid modulation role, has many anti-inflammatory effects, and in animal models have been shown to be lipid independent. These atheroprotective qualities, therefore, do seem to contribute to the improved cardiovascular outcomes demonstrated in patients with niacin. There you go. So the niacin, as opposed to being simply improving on lipid profiles, it appears to be that they have the anti-inflammatory properties. So conclusion, future directions. In recent years, increased understanding of the pathophysiology of atherosclerosis has highlighted different targets for therapy. It is now appreciated that lipid modulation is only one aspect of treatment of patients with atherosclerosis, and intensive management with statins and aggressive strategies to lower LDL-C prevents only a minority of cardiovascular events. There is increasing evidence of the pivotal role that HDL-C plays in atherosclerosis, and to date, niacin is the most effective clinical agent at increasing increasing HDL-C levels, in addition to its other beneficial lipid modulatory effects. So, not only is it effective at raising the HDL, it's effective at regulating the rest of your lipid profile, but most importantly, it actually appears to reduce the inflammation, which we saw later. My brain fried for a second there, sorry. So whether niacin itself is routinely used in the future will depend on the outcomes of the two other large trials, which we looked at before. The AIM, we looked at that a second ago. Unfortunately, it appears that in conjunction with the statins, it is associated with some squirrely other side effects, but it wasn't only a statin, it was also the prostaglandin D2 receptor antagonist. So potentially there could be some benefit. Whether or not the statins should be included, whether or not the other one should be included, it's, as with most things, when you start combining, it can potentially lead to a problem. So, the long and the short, does vitamin B3 work? Yeah. Should most people be megadosing it? Probably not. If you have atherosclerosis going on and you have super high cholesterol levels, maybe. Worst case, make sure you're at least sufficient in it. Eat some tuna, eat some quality sources of vitamin B3, which are most animal products, asparagus, cremini mushrooms. Yeah, that's where we're at. Don't go too crazy about it. Moving forward, Echinacea. And we are now at about the 35-minute mark. So we'll hit the list right here, 35 minutes, and give or take. Boom. In terms of when we start talking about Echinacea. And we have here the Cochrane collaborations, or the Cochrane Review, which is the most respected name in meta-analyses and systematic reviews. And it is the Echinacea for preventing and treating the common cold. And this was the 2014 edition. To be clear, these are ridiculously long. They are breaking down quite a few studies. And So because this is an 85-page paper, or sorry, 90-page paper, I stopped at the appendices. It is a 90-page paper. We are not going through all of it. We will look at the abstract again. You can go through the data analysis yourself if you are so inclined. But here we go. So the background. Echinacea plant preparations from the family Asteraceae. Yeah, probably pronounced that wrong. My Latin's a little rusty. Are widely used in Europe and North America for common colds. Most consumers and physicians are not aware that products available under the term echinacea differ appreciably in their composition, mainly due to the use of variable plant material, extraction methods, and the addition of other components. To assess whether there is evidence for that echinacea preparations are effective and safe compared to placebo in the prevention and treatment of the common cold is the objective. Their research methods, they went through those particular journals. I don't feel like reading through that. You can see it. Or you can go through the link and look at it yourself. There's too much garbage there. It's not pertinent. They only looked at randomized controlled trials, which compared mono preparations of echinacea with a placebo. They did so with at least 2 review authors independently assessed eligibility and trial quality and extracted data. The primary efficacy outcome was the number of individuals with at least one cold in prevention trials and the duration of the cold in treatment trials. For all the included trials, the primary safety and acceptability outcome was the number of participants dropping out due to adverse effects. They assessed trial quality using the Cochrane risk of bias tool. Their main results, there were 24 double-blind trials with 4,631 participants, including a total of 33 comparisons of echinacea preparations and placebo which met the inclusion criteria. A variety of different echinacea preparations based on different species and parts of plant were used. Evidence from 7 trials was available for preparations based on the aerial parts of Echinacea purpurea, which, if you are familiar with Echinacea, is probably the one you should go with. But we'll more on that in a second. There were 10 trials which were considered to have a low risk of bias, 6 to have an unclear risk of bias, and 8 of which to had a high risk. 10 trials with 13 comparisons investigated prevention, and 15 trials with 20 comparisons investigated treatment of cold. 1 trial addressed both prevention and treatment. But due to the strong clinical heterogeneity, heterogeneity, it's an E. I was like, why does that word sound weird? Because it's heterogeneity. But look at C for a second. Yeah, sorry. Let's do that again. Due to the strong clinical heterogeneity of the rules, we refrained from pooling for the main analysis. None of the 12 prevention comparisons reported the number of patients with at least one cold episode found a statistically significant difference. However, a post hoc pooling of their results suggests a relative risk reduction of roughly 10 to 20%. So basically what they're saying is that in the prevention comparisons, we were able to see a 10 to 20% relative risk reduction from those who were not on a placebo. Of the 7 treatment trials reporting data on the duration of colds, only 1 showed a significant effect of echinacea over placebo. The number of patients dropping out or reporting adverse effects did not differ significantly between treatment and control groups in the prevention and treatment trials. However, in prevention trials, there was a trend towards a larger number of patients dropping out due to adverse events than in the treatment group. So, get about that. That's the interesting part. Those who were not really interesting, but in the prevention trials, there was a larger trend of patients dropping out due to adverse events in the treatment group. So basically, there was people who were having issues there. But to be clear, the author's conclusions: echinacea products have not been shown here to provide benefit for treating colds. Although it is possible there is a weak benefit of some echinacea products, the results of individual prophylaxis trials consistently show positive, if not significant, trends. Although potential effects are questionable of questionable clinical relevance. Essentially, what they're saying in there is that prophylaxis is the treatment beforehand, the prevention thereof. It may actually have some weak benefit. While a lot of studies do not show statistically significant results, well, maybe there's something here. We're not sure yet whether it's actually relevant. The key, though, and we'll talk about this later because they actually do it in the discussion, where it does get interesting, is the fact that they admit that, and even in the introduction, they were saying the level of quality of various ones is a key contributor here, or could be a key contributor, is what they say essentially. The fact that they're not standardized for the aerial parts of the Echinacea purpurea may help to indicate what we have going on. Oh, ding, ding, ding. So in the plain language summary, basically they are preparations widely used in Europe, North America for common colds. We reviewed 24 controlled clinical trials. We talked about it before. The majority of trials investigate whether taking the preparation at the onset of cold shortens duration compared with placebo. And although it seems possible that some products are more effective than a placebo for treating colds, the overall evidence for clinically relevant treatment effects is weak. In general, trials investigating echinacea for preventing colds did not show statistically significant reductions in the illness occurrence. However, nearly all prevention trials pointed in the direction of small preventative effects. The number of patients dropping out on or reporting adverse effects did not differ significantly between the treatment and control groups in the prevention and treatment trials. However, in prevention trials, there was a trend towards a large number of patients dropping out due to adverse effects in the treatment groups. So there is that. Basically, moving forward, though, we go towards our discussion. Da-da-da. Results, risk of bias. So our review shows that a variety of products prepared from different echinacea species, different plant parts, and in different forms have been compared to placebo in randomized trials. These preparations contain quite different amounts of bioactive components and hence are not biochemically comparable. Furthermore, trial approaches and methods for cold assessment were highly variable. Taking it together, results from prevention trials suggest that a number of echinacea products slightly reduces the risk of getting cold in healthy individuals. If this conclusion is true, the lack of significance in individual trials could be due to lack of statistical power, i.e., there are too few patients included in single studies. Although it seems possible that some echinacea products are also have effects over placebo for treating colds, the overall evidence for clinically relevant treatment effects over placebo is weak. And honestly, I would agree with that statement overall. The vast majority of echinacea products probably are not going to be clinically relevant. They're not going to be as effective. However, I'd be more interested to see comparisons on products similar to what standard process actually does and uh, produces. I think of the word I wanted there. Anyway, standard process, you can say, well, you. I can vouch. I know there are quite a few people who can vouch for it along with me. You can actually feel. That's a little bit of a stretch of what I'm trying to say here, but you can feel it working. The actual when you have an illness going on and you take the echinacea, you will notice something going on. The actual effect of it having a physiological effect. I keep saying the word effect. Trust me on this. Try it. What's the worst thing to happen? You die. Probably not. Well, I mean, maybe, but maybe not from that. I'd probably say not from that. Long and the short, quality control is what we're talking about here. And actually making sure that you're getting actual echinacea purpurea. That's pretty big. Excuse me. So, overall completeness and applicability for the review, they can identify and include 3 unpublished trials which did not find significant effects over placebo. We are also aware of at least 1 further unpublished negative trial from the USA. During the search for earlier review of Echinacea back in 1994, one of the authors was informed by an expert in the field through personal communication that there were several negative trials from Germany. However, possibly partly of combinations. So again, combination trials. But it seems possible that there are additional unpublished trials that we think that is unlikely that the conclusion of our review would change substantially. The evidence regarding treatments is weak and cannot justify recommendations to take it on a specific product or a specific product. Excuse me. All single prevention trials, including our review, yielded non-significant results, particularly in the smaller trials. The p-values were far statistically significant. Again, we could be looking at a power issue there, which they said before. It's not a people in the study, but we'll see. Agreements and disagreements with other trial studies or studies and reviews. A meta-analysis by Shoup in 2006 was of 3 trials on induced rhinovirus infections included in our review, found that the likelihood of participation experiencing a clinical cold was significantly lower in the echinacea groups. The results were pooled, although different echinacea preparations were examined in the trials. These findings could indicate that the trials were too small to detect a small effect of the tested preparations. This conclusion is consistent with our results. In 2007, another meta-analysis of 3 RCTs investigating the randomized controlled trials, the effectiveness of echinacea products for preventing and treating common colds was published, and this review drew more favorable conclusions, especially on the effect of echinacea on the cold duration than we do. They used different inclusion criteria and also included trials investigating combinations of echinacea. These authors heavily relied on meta-analysis, pooling findings from studies investigating very different echinacea preparations, and from treatment and prevention trials in one analysis. If all these trials are interpreted as investigating the same treatment for the same purpose, then the evidence can be considered as more positive and the conclusions reasonable. For our main analysis, we refrain from pooling studies using different echinacea preparations. So basically, again, while they didn't find statistically significant results in the case of without pooling the data, part of it could just be the fact that they were smaller trials, but also because there are lots of different types of echinacea being used, both species and the preparation and everything else, and parts of the plant. But other complementary alternative medicine interventions for prevention and treatment have been investigated in systematic reviews. The evidence that vitamin C supplementation or probiotics used for previous prevention of the common cold and zinc used for treatment of the common cold are effective is stronger than the evidence for echinacea. So there you go. Evidence for the effects of other complementary alternative medicine interventions is similarly limited or even weaker, such as saline nasal irrigation, increased fluid intake, heated humidified air, garlic, and I'll call you on that one, and Chinese medical herbs. But implications for research, in principle, further research is clearly desirable given the widespread use of echinacea products. However, given the multiplicity and diversity of products on the market, applying the knowledge gained from such studies will remain a challenge to persons without in-depth knowledge of herbal preparations. The use of chemically well-defined preparations is recommended to improve comparability of the results, compatibility of results from different studies. It would be desirable if experts in research on common colds could develop recommendations for a core set of outcome measures to be used and reported in randomized clinical trials. Trials investigating the prevention of colds need large sample sizes as the potential effects of echinacea are likely to be very small. So, long and the short there, take it for what it will. They freely admit the small sample size is a problem. They admit there's different preparation, and that in and of itself is a big, big problem. But like I said, try for yourself. Particularly since we bring us to this next one here. Antibiotic resistance. What are the opportunities for primary care in alleviating the crisis? And because this one's not specifically about echinacea in and of itself, what we're looking at here, though, is the potential for it to be used. Echinacea as one thing, vitamin C, zinc, and probiotics, as we mentioned before, in dealing with antibiotic resistance. Why is that important? Well, as we see here, preventing patients from developing an acute respiratory infection will obviate any need for antibiotic use downstream. So stopping them from getting that, great idea. Hygiene measures such as physical barriers and hand hygiene and possible vaccination and exercise may also be effective. Now, again, that's partially why we're not going this. But a large number of complementary alternative medicines, as we said before, zinc, vitamin C probiotics, are being proposed for preventing and treating ARIs, but evidence for efficacy is scarce. So what we're going to do here is look at echinacea in and of itself here. Again, you can read through the actual paper itself. It's down below. But probiotics, echinacea, and vitamin C are sometimes suggested for preventing ARIs or acute respiratory infection. Vitamin C has been used for more than 80 years, although a Cochrane review concludes that it does not reduce the incidence of common cold. Yeah. Another Cochrane review found that trials investigating echinacea, which we just looked at before, preventing common cold, did not show statistically significant reductions in illness occurrence. However, nearly all prevention trials pointed in the direction of small positive benefits. Importantly, the available echinacea products differ greatly in content of active components, and due to significant difference in the preparations tested, it is not possible to draw strong conclusions about the effects of echinacea in either preventing or treating common colds. However, probiotics lab microorganisms also propose preventing ARIs and are found to be marginally better than placebo in terms of number of participants who experience at least one episode of an acute upper respiratory tract infection. Further trials are needed to strengthen the evidence, but yeah, echinacea is commonly used, although its products have not been shown to be no benefit. We went through all that before. Yeah, long and short, we are dealing with lots of antibiotic resistance and epidemic thereof. Might be a good idea to get in some alternative ones. Just saying. All right. Last one here, and this one's a little bit of a scrollier one. We have here the effect of an echinacea-based hot drink versus oseltamivir in influenza treatments. We're now talking about echinacea for the flu. And this is a randomized, double-blind, double dummy, multi-center, non-inferiority clinical trial. And this one, we're talking about echinacea having antiviral activity against the flu in vitro. It has antiviral activity against influenza viruses in vitro, and has traditionally been used for the treatment of colds and the flu. This randomized double-blind trial was completed where it compared a new echinacea formulation with a neuroamidase inhibitor, which is oseltamivir, the gold standard treatment for influenza. Following informed consent, 473 patients with early influenza symptoms were recruited in primary care in the Czech Republic and randomized to either 5 days of oseltamivir, followed by 5 days of placebo, or 10 days of echinacea purpurea-based formulation called Echinaforce hot drink. The proportion of recovered patients with influenza symptoms rated as absent or mild in the evening was analyzed for non-inferiority between treatment groups using a personalized Wilcoxon test with significance levels set at alpha of 0.05 and two-sided test using a confidence interval approach in the protocol sample. Yeah. Biostatistics. Yeah. Recovery from illness was comparable in the two treatment groups at 1.5% versus 4.5% after 1 day, 50.2% versus 48.8% after 5 days, and 91.1% versus 84.8% after 10 days of treatment with Echinaforce hot drink and oseltamivir, respectively. Non-inferiority was demonstrated for each day and overall, with a confidence interval of 95%. Very similar results were obtained in the group with virologically confirmed influenza virus infections and in retrospective analysis during the peak influenza period. The incidence of complications was lower with the Echinaforce hot drink than with the oseltamivir, and with fewer adverse effects, particularly nausea and vomiting, were observed with echinacea. I'm just gonna call it echinacea. Screw the friggin' trade name. I'm done. Done trying to do that. Echinaforce hot drink. All right. So the ephedra, the Echinaforce hot drink, is as effective as oseltamivir. What the hell is the brand? So I want the trade name for that one. Oseltamivir. Tamiflu. Duh. That's what I thought. But yes. So Tamiflu versus echinacea. We'll go easy. It's as effective as Tamiflu in the early treatment of clinically diagnosed and virologically confirmed flu infection with a reduced risk of complications and adverse effects. It appears to be an attractive treatment option, particularly suitable for self-care. So it presents as a potential threat to human beings with seasonal epidemics and occasional severe pandemics, following reassortment of viral antigens. So they evolve a little bit. The World Health Organization, whatever. It's an epidemic. Pandemic gets everywhere. Yeah. It's characterized by involvement of lower respiratory tract or cough, accompanied with systemic complaints including headache, myalgia, and fever. Acute onset of cough and fever are good clinical predictors associated with positive tests for influenza in 79 to 88% of patients during acute epidemics. Results depend to a large extent on detection and sampling methods as well as the severity of the epidemic. Flu viruses replicate predominantly in the airway epithelia, but also in various other host organs, and tissues, leading to airway congestion, inflammation, and necrosis. I really don't feel like going through the rest of the flu pathophysiology or pathogenesis, rather. Yeah, basically, we're looking here antiviral effects in 500 people. So let's go through the patient flow diagram real quick. There was 473 assessed. They excluded 0. They all consented, all ready to rock. They randomized them. 237 went to the intervention. 236 went to the other one. Which intervention is which? Da, da, da. So I believe the second one is the Ostamivir, the Tamiflu. Who got which? 2, 3. So based on the dropouts. Ugh. It's okay. So of which, there we go. 237 and of the 237, 236 patients allocated to the two treatment groups. So Echinacea got 237 and the Tamiflu got 236. That's what we're looking at here. Here's our little flow chart. Of which they all got allocated. They all got their treatment. Of the follow up, we lost 3 in the Echinacea group and lost 3 more in the follow up to that. So both sides lost 3. And then in the analysis, there was 30 who were excluded from the analysis for either excluding or violating the exclusion criteria. There was 11 who were non-compliant in the Echinacea group, 10 who were non-compliant in the 10 in the there were 10 who were non-compliant in the Tamiflu group, and then in the Echinacea groups, there was one person who went and used a non-permitted medication. So basically, they went and messed it up. We lost another 16 from analysis in the Tamiflu group and 30 altogether in the Echinacea group, which at the end left it with 203 and 217. So baseline influenza symptoms right here, we can take a look at that, which are cough. So they were based on the personal rating. There was an individual rating system, whether it was moderate to severe. Cough was higher in the Echinacea group. The fatigue, myalgia, we can go through that there. You take a look. In terms of days of treatment, we have our percentage of patients right there. Portion of patients with alleviated influenza symptoms in the protocol group, 420. A total of 9.9 did not respond to the Echinacea force group treatment in comparison to the 15.2 who did not respond to the Tamiflu. So slightly less people had non-responses who didn't get a benefit from the Echinacea versus Tamiflu. So mildly better there. Basically, at the end here, we have the clinical efficacy and safety of the novel formulation Echinacea purpurea of the Echinaforce hot drink in the comparison to the Ostamivir Tamiflu in patients with early symptoms of the flu. It showed that it matched the large clinical trials showing superiority of, that along with the matching of Tamiflu and its benefit over placebo. An earlier inclusion of patients was achieved by recruiting patients in primary care. Under these conditions, non-inferiority of Echinaforce of Echinacea to Tamiflu was demonstrated in terms of recovery from illness. So there was intention to treat is kind of the idea they're going with here. They intended to treat both ends of it because they intended to treat the Tamiflu group. They intend rather than give them placebo versus Echinacea, and the person has the flu and they do nothing in case Echinacea didn't work, in case the drink didn't work. Rather than give them nothing and then you're just being a dick to the patient, they're comparing it versus the accepted treatment. So some got Tamiflu, the other ones got the Echinacea, and there you go. And basically, again, you can go through, look at the rest of it yourself. We're already at an hour mark right here. We're going to close out in a second. Unless there's any other questions. Long and short, neuraminidase inhibitors are the main current therapeutic option for the treatment of influenza and are recommended by authoritative bodies in several countries. However, the risk of drug resistance, we said before, safety issues, and limited availability challenge their usefulness for the early influenza therapy in reality. Echinacea hot drink, or Echinacea, has been demonstrated to be an attractive therapy for acute influenza treatment with a better safety and comparable efficacy profile to the neuraminidase inhibitor oseltamivir, or Tamiflu. Its availability is an over-the-counter medicine that allows for very early treatment to start, which is central for treatment success with any intervention. But again, going back to the Cochrane review, make sure you are using quality stuff. Don't just grab the random stuff from CVS. Not a good idea. All right. So yeah, all the studies are down below in the description. Take a look at them. Look through them yourself. Have some fun. And other than that, guys, gonna keep working. Hope to get back to some of the more regular videos. Hopefully you enjoyed it if you made it this far. If you're watching on the replay, thanks again. Otherwise, like and subscribe. You know the deal, guys. You don't have to say it anymore. And yeah, I'll see you next week.